Welcome to this video on spinal pain and common spine disorders, presented by Dr. Fahmy. Our learning objectives are to define and categorize low back pain, identify its causes and risk factors, explain terms like sciatica, understand physical and neurological exams, outline diagnostics and management, and recognize spinal deformities. An overview of spinal anatomy includes the vertebral column, key components like discs and nerves, and its functions such as supporting weight and protecting the spinal cord. Next, we will focus on understanding low back pain, commonly referred to as LBP. Low back pain is discomfort between the lower rib margin and gluteal folds. Pain types include localized, referred, and radicular pain, such as sciatica. It is classified as acute, subacute, or chronic based on duration and impacts mobility, sleep, work performance, and psychological health. LBP affects 60 to 80% of individuals and is a leading cause of disability globally. Peak incidence is between ages 30 and 50. The economic burden is substantial, with indirect costs often exceeding direct healthcare costs, reaching over $100 billion annually in the U.S. alone. LBP is categorized by duration. Acute LBP, lasting less than 6 weeks, is often mechanical and resolves with conservative treatment. Subacute, 6 to 12 weeks, may involve persistent inflammation. Chronic LBP, over 12 weeks, is multifactorial and requires multidisciplinary management. Mechanical LBP is the most common, originating from the spine, discs, or soft tissues. Examples include muscle strain and herniated discs. Non-mechanical LBP has an inflammatory or systemic origin, with red flags indicating serious pathology such as infections, tumors, or autoimmune conditions. Red flags are critical signs of serious underlying pathology. These include a history of malignancy, unexplained weight loss, fever/chills, history of trauma, immunosuppression, IV drug use, progressive neurological deficits like Cauda-Equina syndrome, and pain not relieved by rest or worsening at night. Yellow flags are psychosocial factors that increase the risk of chronic pain and disability. These include catastrophizing, fear avoidance beliefs, depression and anxiety, low job satisfaction, and passive coping strategies. They influence pain perception and require early psychological support and education. Common workplace contributors to LBP include repetitive lifting with twisting, prolonged sitting or standing, whole body vibration, poor ergonomics, and inadequate breaks. At-risk professions include construction workers, nurses, manual laborers, and office workers. Preventative measures involve ergonomic adjustments, job rotation, and core strengthening. We now explore the specific causes of LBP. Musculoskeletal causes of LBP include muscle or ligament strain, degenerative disc disease, facet joint dysfunction, and sacroiliac joint dysfunction. These range from acute injuries improving with rest to chronic issues due to wear and tear or joint inflammation. Nerve root involvement causes include a herniated disc, spinal stenosis, spondylolisthesis, and foraminal narrowing. Symptoms often involve radicular pain, numbness, or weakness, with spinal stenosis causing neurogenic claudication relieved by rest or flexion. Non-spinal causes of LBP include renal conditions like kidney stones and pyelonephritis, and gynecological issues such as endometriosis and PID. Vascular causes, like abdominal aortic aneurysm, are surgical emergencies, while GI issues such as pancreatitis or gastric ulcers can also refer pain to the back. Inflammatory and infectious causes include ankylosing spondylitis, common in young men with morning stiffness over 30 minutes, and tuberculous spondylitis, characterized by night sweats and weight loss. Discitis and osteomyelitis involve bacterial infection, while malignancy is indicated by constant progressive pain, worse at night, and unrelieved by rest. Next, we will review the signs, symptoms, and key terminology related to spinal pain. Common LBP symptoms include localized, dull pain over the spine, and radiating, sharp, shooting pain, often due to sciatica. Stiffness is worse after rest. Red flags include numbness, tingling, weakness, or loss of bladder/bowel control, which may signal a surgical emergency like Cauda-Equina syndrome. Key terms include sciatica, which is a symptom of shooting pain along the nerve pathway, often due to disc herniation. Radiculopathy involves nerve root dysfunction, causing pain, numbness, weakness, and decreased reflexes. Referred pain is perceived in a distant location due to shared neural pathways. Pain patterns can help localize the source. Midline pain often suggests disc pathology, while paraspinal pain suggests muscle strain or facet joint issues. Pain with extension suggests facet joint involvement, while pain with flexion points to disc pathology. Morning stiffness over 30 minutes suggests an inflammatory cause. We now transition to the physical and neurological examination necessary for evaluating spinal pain. Inspection involves observing posture, gait, spinal alignment, and any skin changes. Palpation identifies tenderness in spinous processes, paraspinal muscle spasm, or sacroiliac joint tenderness. These findings help localize the mechanical source of the pain. Range of motion testing includes flexion, extension, lateral flexion, and rotation. We look for pain, guarding, or asymmetry during movement. Pain with flexion suggests disc issues, while pain with extension may indicate facet joint involvement. Neurological testing includes sensory testing to map dermatomes, motor testing to check myotome strength, and reflex testing. Deficits in these areas, such as sensory loss or decreased reflexes, are critical signs of nerve root compression or spinal pathology. Special tests include the straight leg raise, which is positive if pain radiates below the knee, indicating L4S1 radiculopathy. The slump test and Faber test are also used to assess sciatic nerve irritation and sacroiliac joint or hip pathology, respectively. Our next section focuses on the diagnostic approaches used to evaluate spinal pain. A thorough history is essential, covering onset, duration, pain character, location, and associated symptoms. Always screen forward and yellow flags, which are crucial indicators of serious pathology or barriers to recovery. Imaging modalities vary based on suspected pathology. X-rays are best for bone structure and alignment. MRI is the gold standard for soft tissues like discs and nerves, and CT scans are better for detailed bone evaluation, particularly in trauma. Laboratory investigations are used to detect systemic causes. CBC can suggest infection or malignancy. ESR and CRP detect inflammation. HLA-B27 indicates spondyloarthropathies, like ankylosing spondylitis, and tumor markers may screen for malignancy. Clinical reasoning involves categorizing pain after history and exam. If no red flags or neurological deficits are present, conservative management is appropriate. If red flags or progressive deficits exist, immediate referral for appropriate imaging, usually MRI, and multidisciplinary care is necessary. We now move to the crucial section on the management and treatment of spinal pain and disorders. Conservative management involves activity modification, encouraging light activity, and avoiding heavy lifting. Postural education and correct ergonomics are vital. Heat or ice therapy helps reduce inflammation and relax muscles. Manual therapy includes mobilization and massage by trained personnel. First-line pharmacological treatments include paracetamol, which offers modest efficacy, and NSAIDs like ibuprofen or diclofenac, which reduce pain and inflammation. Adjuncts include muscle relaxants for spasms. Opioids should be avoided for routine use, and gabapentinoids are reserved for confirmed radicular pain. Physiotherapy involves therapeutic exercises like stretching, core strengthening, and stabilization training. Programs may be flexion or extension-based. Other modalities include TENS, dry needling, and acupuncture, with some evidence for chronic low back pain. Cognitive behavioral therapy, or CBT, is effective for chronic LBP, particularly when combined with physical therapy. It focuses on reducing fear avoidance behavior, increasing activity, and teaching coping strategy through techniques like thought challenging and graded exposure to movement. Interventional procedures include injections like epidural steroid injections for radicular pain and facet joint injections for arthropathy. Radiofrequency ablation destroys nerves for chronic facet joint pain, and trigger point injections treat myofascial pain syndrome. Surgery is indicated for emergencies like cauda equina syndrome or progressive neurological deficits. It may also be considered for persistent pain or instability that fails conservative care. Common procedures include discectomy, laminectomy, and spinal fusion. We will now discuss common spine disorders and deformities. Lumbar disc herniation often occurs at L4, L5, or L5S1, causing unilateral leg pain, radiating pain known as sciatica, and potential muscle weakness. Diagnosis is confirmed by MRI. Management is conservative initially, with microdiscectomy reserved for persistent deficits. Spinal stenosis is the narrowing of the spinal canal, common in those over 60, often due to degenerative changes. Key symptoms include neurogenic claudication, relieved by rest or forward flexion. Diagnosis uses MRI, and management includes flexion-based physiotherapy or laminectomy if conservative treatment fails. Scoliosis is a lateral spinal curvature over 10 degrees. Types include idiopathic, congenital, and degenerative. Clinical signs include uneven shoulders and a rib hump. Management depends on the Cobb angle, ranging from observation to bracing or spinal fusion surgery. Kyphosis is an exaggerated thoracic curvature, while lordosis is excessive lumbar curvature. Causes range from postural issues and Scheuermann's disease to obesity and pregnancy. Management involves physiotherapy, bracing for children, and surgery for severe symptomatic cases. Prevention strategies include regular physical activity and maintaining a healthy weight to reduce mechanical stress. Ergonomic practices and safe lifting techniques are crucial, along with preventative physiotherapy education for high-risk groups. The prognosis for acute LBP is generally favorable, with 90% improving within 6 weeks. Poor prognosis indicators include fear avoidance beliefs and inadequate early management. The goals of management are to relieve pain, restore function, and prevent recurrence through patient education. Thank you for watching this video on spinal pain and common spine disorders.